I'm Georgia Sarquella-Brugada. I'm at the Pediatric Arrhythmia and Inherited Cardiac Diseases and Sudden Death Unit at Hospital Sant Joan de Déu. And welcome to this talk that we are going to be exploring Brugada syndrome in children and knowing what's new in the field. So as you all know, first patient identified with Brugada syndrome was a child. And in fact, in the first abstract and also in the first published paper, most of the patients come from the pediatric background. So thinking that Brugada syndrome, it's an adult disease, it is not real. But of course, the biggest number of patients having Brugada syndrome are adults, and manifestations in children are really the big cases, the very severe cases that manifest at early ages, even at fetal time. So as you all know, Brugada pattern, which is the cuff tape ST segment elevation in right precordial leads, is the manifestation. And in fact, as was reported at the first paper, it's what has become a matter of many publications and many subjects of interest and research in the following years, after it was described in 1992, has increased year by year. What is very important to know, and it was a little bit of discussion at the beginning, is that the cuff type 1 ECG is the only diagnostic, and what it's called type 2 and 3 or saddleback are suggestive of Brugada syndrome, but it's not diagnostic of Brugada syndrome, no. So it's a mistake to recall a patient, Brugada patient, with only a type 2 or 3 ECG pattern. What is important and what it's been proven is that ashmalin or sodium channel blockers drugs given at a patient can easily manifest the Brugada pattern and may be of interest for like unmasking the underneath pattern in those patients. We also know that genetics is very important, and already in the late 90s, it was described the relation with SCN5A, alpha subunit of sodium channel, described at chromosome 3 as responsible of, let's say, around 25% of cases. The rest of the cases may be related to a polygenetic disease or oligogenic disease or other diseases or other type of mechanisms that may explain the rest. So even though genetics are important for those cases that are SCN5A positive, having a negative genetic test result, it's not, we cannot discard that this patient has a Brugada pattern. What is most important in patients with Brugada, and especially in children, it's the presence of temperature changes. Fever is one of the main provocative tests for unmasking a Brugada pattern, and it's very important in pediatric population for several reasons, because their temperature can reach high degrees easily, and they have many viral infections that they may be under fever or febrile very often, even once a month in the first 5 years of age. So we can easily use ECGs performed during febrile periods in order to unmask or to reveal if there is any change in the pattern, in the ECG pattern for those patients. Since until let's say 2012 or 13, the only big paper related to Brugada syndrome in children was the collaborative paper from several groups, and in fact, what it was said that many of the patients with Brugada syndrome are asymptomatic, as in other population, 35% were genetically positive, and in 5% of the cases they had a spontaneous diagnostic disease, and less than 2% needed an ICD. So in fact, it was a very rare disease with a very low prevalence of symptoms at pediatric ages. But as it's been said from the very beginning of the disease, febrile seizures, febrile syncopes, so fever-related symptoms are very important in this population. And this may unreveal the underneath pattern for Brugada syndrome. So, and this is, I think, one of the most important papers relating to that is the fact that febrile seizures can mask an underneath Brugada syndrome and have to be very well studied in those patients having either a familial background of syncopes or sudden death, or a family with Brugada seizures, history of Brugada seizures. And it's very important that and to introduce Brugada syndrome in the minds of many neurologists that deal with febrile seizures or atypical febrile seizures in childhood. So this is the result of a collaborative paper that a very strict work that was performed in the last 3-4 years with more than 650 patients with Brugada syndrome coming from different groups in all over the world, that we could study certain points, and we could see that even though the prevalence of manifestation was at the 40, when the person reaches the 40s, it's true that there is a peak of incidence at the first year of life in those cases at having great manifestations or very severe manifestations, especially in childhood. So how do we do the follow-up of children with Brugada syndrome? Mainly, it's annually we perform a 12-lead ECG, but we call it modified 12-lead ECG or Brugada position, where we put V1, V2, V3, V4, V5, V6 in a parasternal position. And of course, we give a paper or we give a note, a letter to the families that they have an ECG performed while fever in order to try to see if fever can unmask any covered or masked pattern. Of course, during the follow-up, we are very strict saying that try to avoid Brugada drugs, what we call Brugada drugs, which are the sodium blocking, sorry for that. We are that drugs that are blocking sodium channel. And of course, if there is the presence of any symptoms, if there are any syncopes, seizures, or palpitations, they have to come to emergency department. Which is our casuistic. We have around 140 patients under the age of 18 years, and the circumstances that we know them, it's because 4 of them have had an aborted sudden death, 3 of them have come for atypical febrile syncopes, 3 of them had supraventricular arrhythmias, and 4 having very severe cardiac conduction system dysfunction, and 8 of them because having an abnormal ECG that obliged to study deeply the case. We have a follow-up which is not sure, which we have more than 94 months of medium follow-up, and we have had no sudden death so far after diagnostic, and we have 7 patients carrying an ICD, with 3 of them with three of them having appropriate shocks, and none of them have had inappropriate shocks so far. 5 of our patients have needed or need quinidine, and in 3 cases they still only need pacemaker, and that we know that in some of them may change to ICD when they grow old. This is what we've learned from previous cases. And in 2 cases, we needed to perform substrate ablation, epicardial substrate ablation of the ventricular tachycardia in patients receiving shocks and having a lot of antiarrhythmic medication that was not controlled. What we've learned is that, once again, fever is the most important precipitating factor, and that if there is a spontaneous type 1 ECG, they have more tendency to have arrhythmias. And in children, we have found no gender differences. Drug challenge in children have been reported in other studies at Great Ormond Street, at Brussels, And we are under revision of our series of what we were performing at the beginning, flecainide test. And we have to say that we have one complication, severe complication, that one of our patients is the only complication, in fact, that we had electromechanic dissociation during flecainide challenge, and we had to do cardiac massage during 10 minutes. That was the time that flecainide stopped or slowed down, and it was quite of a complication. Nothing happened at the end, but we had a very bad time, of course. So when performing our study on flecainide challenge, we have to say that having a family history of high or even low risk of Brugada syndrome is one of the predicted positive values. And of course, having an abnormal basal ECG and with family history and with abnormal febrile ECG are also predictive values for positive flecainide test. When do we perform family screening? We perform it from birth by doing ECGs, annual ECGs, and ECG during fever. Of course, if it's possible, and if it will not prolong the time of trying to control the fever. We do genetics if available, so if daddy has Brugada syndrome and has a positive genetic test, we check for these genetics at the child, and if it's positive, we follow up. If it's negative, we send the patient home because it's not a carrier of that disease, if it's a known pathogenic genetic mutation. When we have positive flecainide test in our patients, that we perform flecainide test around puberty, if everything is okay and nothing has happened before puberty, we perform around puberty flecainide or ashmalin test, now ashmalin, after that complication we had. And we have to say that if patient has a normal basal ECG, and most of the time EPS it's negative, and only the 2 positive EPS that we have seen in our patients after drug challenge have been positive. So meaning that really that our patients are at very low risk. So what about ablation? In fact, ablation it's been performed in adults with great success, and of course we tend to wait that what happens in adulthood before we plan to do it in children. And in fact, why are these ablations performed in Brugada syndrome? Mainly because we want to reduce arrhythmias at an early and mid-term follow-up, and is appropriate when there is an electrical storm or documented appropriate shocks. And of course, why is it good? Because it normalizes ECG, normalizes drug test, and it prevents inducibility. So it's a great thing, and it has been shown that it's a great thing in adults. So, but we still don't have a very long follow-up on what's happening next. But the fact is that probably its indication maybe would be for patients at high risk of presenting ventricular arrhythmias with a spontaneous type 1 ECG and sudden death, cardiogenic syncopes, and it might be appropriate in patients with sufficient risk to deserve protection with an ICD. For example, in a type 1, spontaneous type 1 ECG, which is asymptomatic but is inducible, maybe it could be considered to perform an ablation before implanting an ICD. What it would happen with children is that only in those cases which are really severe and we are blocked and we have many chocks in those children would be considered. And in fact, it has been in our center already in 2 children with a very good results. So there are several questions that come up to us during when doing the follow-up of Brugada children. We have a patient which is genetics, has a positive genetic test and has fever. Do we need to admit this patient at the hospital? Well, we perform an ECG, and if the ECG looks good and we can control the pattern, we can send the patient home, of course. if we have a patient which is genetic positive and needs a drug which is at the list of forbidden drugs, once again, we need to balance the needs and the consequences. And of course, if it's a patient with an emergent surgery that needs to be taken for general anesthesia and we have no other choices, of course, we do a monitoring of this patient with ECG and to be ready for no matter what. And we have to make our life easy. But the big deal is what happens with those patients having persistent spontaneous type 1 ECG. That's important because in those patients, we have to be really strict with drugs, no fuchs on that. And of course, we have to give medication to avoid those drugs that are also at least even for medicating them if they need it. But of course, fever, it's the most important thing. And those are the real Brugada children at risk, those having a spontaneous type 1 ECG with fever. So let's finish with one case. We have a child that we met her while she was 3 years of age. She had an atrial flutter. We gave flecainide and it came up with a Brugada pattern. And she did a syncope and a complete AV block. After that, she was paced with a single chamber pacemaker because she maintained that block. And we could find out after a while that she was carrying 2 mutations in sodium channel that by that time we could say that it was mainly most Lèvres-Lenègre syndrome rather than a Brugada pattern, because the fact it was a cardiac conduction system disease rather than ventricular arrhythmias. At the age of, still with a complete AV block, at the age of 8, she was upgraded to a dual chamber pacemaker. But at 10 years of age, we could find out that she was having supraventricular tachycardias. We put her in the EP lab, nothing was inducible. And at the age of 13, he presented with a syncope, with an atrial flutter, atrial fibrillation, and 3 episodes of non-sustained ventricular tachycardia. So she was changed, or she was switched to a dual chamber ICD. And 2 years after, she developed ventricular tachycardia, needing high doses of quinidine that could not control several episodes of ventricular tachycardia. And we decided to do a substrate ablation, epicardial substrate ablation in this patient. So this is the first ECG we had on her. This was a very quick flutter that was performed at the beginning, and after the first follow-up, she ended up having this Holter with AV block, and what was severe and very symptomatic one. After that, she sometimes had some type of rhythm that could be controlled, but she was needing pacing most of the time. We had the episode of SVT that could not be induced at the EP lab, and also some episodes of ventricular tachycardia that finally, with this basal pattern, we put her on the EP lab to perform substrate elimination. Also at exercise test, she was having several runs of non-sustained ventricular tachycardia. So this was her pattern when we carried her to the EP lab, and before Ashmelin, we do an endo and epi cartomap, and we could see no difference. But with Ashmelin, we could see that there was a focus there or an area there that had pre-potentials and some potentials that we could elaborate a map in that area that could be ablated, and this was the area of ablation, around 8 square centimeters, and this was the Ashmelin test before, and this was the pattern before, and this was the pattern after the ablation, that we could see that we have this flattened ST segment elevation. And this was the comparison of the ECG pre and post Ashmolean, and during RF and after RF, that we can see this very specific flattening of the ST segment. So this is the basal ECG after 2 months of the ablation. She has had no arrhythmia so far that is registered on the ECG, and she will keep on her ICD as well. So as a conclusion for Brugada in children, we can see it's very important that syncopes in those patients can mask all types of diseases. Brugada syndrome affects all ages. In children, disease can change a long time, and this is very important. Diagnostic tools are available at any age. We can perform drug challenge at any age if needed. Fever and febrile seizures are very important in children. A strict fever control is absolutely mandatory. And for the follow-up, we perform ECG annually, drug challenge when needed, EP study if drug challenge is positive, quinidine if needed, and then we may need ICD if this patient would be at risk. And therapeutic tools are, of course, avoiding fever, avoiding drugs, quinidine, and ablation in those cases. So this is the big conclusion. Children are weird, so we have to be prepared for no matter what. Thank you very much. I hope I'm open to questions.